Hi, this is Tal Lee. Welcome to tonight's webinar. This is the secrets of the USMLE Step 1, how to dissect any question on test day. This is something that we talk about in first aid, and we're going to have one of our RX first aid editors here walk you through how to do it. So it should be a fun webinar, and we already see that there's a bunch of people out there, so look forward to interacting with you. So first of all, my name is Tal Lee. I am an associate clinical professor of allergy immunology at the University of Louisville in Kentucky, the United States. But most people know me as the lead editor for first aid for the USMLE Step 1. I'm also editor and founder of USMLE-Rx and the Scholar-Rx, bricks as well. My co-presenter tonight is Dan. Dan, would you like to introduce yourself?
Yes, Dan Griffin here. I'm currently a Poem CC fellow at UMKC in Kansas City, Missouri. Been working with first aid usually through most of the Express videos for the last couple of years, and have I think it's real fun how you can learn to just approach questions a little differently. And that's kind of what we're going to talk about tonight.
Great, fantastic. Now we also have some panelists as well, and what they're going to do is they're going to answer questions that you may have, and you'll notice that if you're on a computer, there is a panel on the right side, and in that panel there's a sub-panel that says questions. So you can feel free to ask questions about preparing for the Step 1, dissecting USMLE questions, so forth, while Dan here is going through the primary sections. First of all, I'd like to introduce Manover. Manover, would you like to say a couple words?
Sure. Hi everyone, it's very nice to be here this evening. I'm Manover Diol, and I help manage the Step 2 products here at RX, and I'm excited to be answering your questions tonight, so feel free to ask anything that you'd like.
Great. We also have Sean Nanji. Sean.
Hey guys, always nice to be on these webinars. Students always find them helpful. Looking forward to answering your questions, so feel free to ask away.
Great, fantastic. So, so let's, with that, what I want to do before we get too far is I want to know, who you folks are out there, since you know a little bit about us now. So this is an interactive session, so we're going to make you think a little bit, but just to make sure you know how to use the audience response system, whatnot, I am going to open up a poll. I'm going to select a question here, and I'm going to ask you to choose a single best answer that describes who you are, and then we'll share the results with folks. And so there should be a poll that you should just respond to, and we'll leave the poll open for about 15-20 seconds, because it does take a little while for all the responses to tabulate. So so go ahead and jump on there and pick your answers. Pick an answer, and then I'll share in just a little bit. All right, looks like roughly half of you folks have answered. I'm going to keep it going a little bit because I just want to make sure you guys are comfortable using the interactive poll. Again, if you're on a computer, it should be in front of you. It also should pop up, on your iPhone app or your Android app. So you shouldn't have to do too much. All right, looks like we've got 80% of the folks have answered, so that assures me that you guys know how to use it. So let me go ahead and close the poll, and share a little bit about who's on tonight. Looks like we've got close to half the group, actually more than half the group, three-quarters of the group being IMGs, but half coming from abroad. We also have 25%, 30% of our students as in the U.S. as well too. So again, welcome everybody. All right, so I'm going to go ahead and drop that poll and get into the presentation. So over the next hour or so, we're going to do, we're going to talk about questions type. We're going to talk about the anatomy of a board style question. Why do you need to dissect? Why do you need to be able to dissect questions on the USMLE? And then we'll go through a couple sample dissections today. It'll be we're going to do a bit of a focus on GI. Change it up from what we did last time. Provide some dissection tips, some study advice at the very end. We do have a special raffle. We'll be raffling off our USMLE-Rx package, RX 360. That includes our question bank, our digital flashcards, our videos, as well as our brand new RX Bricks, which is really exciting. It's a new digital curriculum system that can help you with school and the USMLE. And then we also have a special offer as well. So hang on, and you gotta be present at the raffle to pick up your prize if your name gets called. And then at the very end we'll answer some questions about preparing for USMLE Step 1, question dissections, that type of stuff. So that's it. All right. So the USMLE Step 1, just to give you a quick overview, it's a one-day exam, as you all know, 7 blocks, roughly 40 items per block. On the exam, and this is where format matters. It's mostly it's actually all single best answer items. There are a few items with multimedia. About 15-20% will have images. Most of the exam items or questions will either have a clinical vignette or scenario, and the majority of the time you're going to be dealing with more than a single step in terms of the logic and the reasoning. And so you might have heard of these multi-step questions, or these integrated step questions. And so what happens is that the USMLE very often likes to take multiple related concepts, puts together into a clinical vignette, and forces you work through these related concepts to answer the question. So for example, here you see a clinical vignette where you've got a young Caucasian woman who presents with a 5-day history of occasional double vision. That's bilateral and symmetric, and what's the symmetric ptosis. And then it asks you, what is the most appropriate diagnostic test? So you recognize almost immediately that this has got to be more than a one-step question, right? Because it's not even asking you for the diagnosis, right? You got a presentation, you're already jumping ahead to what the diagnosis is. So you've already figured that out, right? So step 1, make the diagnosis. And in this particular case, with a young Caucasian woman with the bilateral ptosis and the double vision, the most likely diagnosis is going to be something like myasthenia gravis. You can argue for other conditions like multiple sclerosis, but the finding tends to be unilateral, and there's a greater likelihood that you'll see a presentation with a young African American woman. So in order to figure out what the most appropriate diagnostic test is, you got to get to the the diagnosis, and then you can actually think about the diagnostic test. So that's how you break it down this question. And if it is myasthenia gravis, then what is going to be the most likely diagnostic test? So the most appropriate diagnostic test is going to be something like the tensilon test, which is a short-acting acetyl cholinesterase, idrophonium. So that's been the classic test. In the United States, it's largely been replaced by anti-acetylcholinesterase and antibodies. Uniformly, that'll probably be the new answer. But idrophonium is still used in other parts of the world. So just as an FYI. So again, that's an example of a 2-step question. And and when Dan talks about it, he'll talk about walking through the various steps in terms of figuring out the logic and then using that to get to the appropriate answer. All right, so the USMLE, if you look at their blueprint, the items, as you can see, focus on a couple of major areas. One is applying foundational concepts. As you can see, that's involving more than half the items. and then many of the items have obviously pathology, physiology, and then application of general principle. Obviously adds to more than 100% because there's often multiple integrated concepts that are being addressed or tested in these multi-step questions. All right, so at this point, with regards to how you dissect a question, I'm gonna hand it over to Dan Griffin to talk about the particulars of question dissection. Dan?
All right, we'll get kind of rolling here. So the first thing I just kind of want to point out is that there kind of are a few little steps you can take, and the first one of those steps is realize that each question is written with a specific objective, or they're trying to test a specific topic area or content area. So something that you can ask yourself kind of when you're taking a question, you're getting to something that you're either stumped on or you're not real sure is, what do I think the question writer is actually trying to test me on here? And if you can just kind of think of that, sometimes that'll help you. So a way that can help you is, let's say you get a question on pancreatitis and they're asking you for a treatment option for pancreatitis, and you've narrowed it down to between two answers. So first you're thinking, they're asking me about pancreatitis. Now I know that, that's kind of the topic that they're testing me on, and that the objective here is to ask me the treatment for pancreatitis. The two answers that you've got it between are some advanced surgical option, and then just the usual treatment for pancreatitis, which is like MPO, IV fluids, and maybe some pain medicine. So as a step one student or someone taking step one, do you think that they really want you to know this potential advanced surgical treatment option that you read about in NEJM 2 weeks ago that they presented as, this kind of new breakthrough therapy? Or do you think they just want you to know that you need to treat pancreatitis, just by not letting them eat, giving them some IV fluid and pain medicine? Well, if you kind of just step back up from it from that perspective, you're going to realize that they just want you to pick the MPO, IV fluid, and those type of things. So that kind of can help you approach that question. The next statement is that all the data that's given to you in a question is there for a reason, and it's there to help you arrive at an answer. It's not given, they're not giving you information to trick you. Now, is all the information needed to answer the question? No, it's definitely not. There is going to be some information there. You don't need to answer the question, but that doesn't mean that you need to approach questions thinking that they're trying to trick you. If you approach questions thinking that they're trying to trick you or trying to decide if this sentence is relevant or this sentence is irrelevant, you're going to end up basically putting yourself into more of a quandary than you are going to help yourself out. And our job here is to get as many questions right as we can. And the best way to go about that is to, every bit of information that they're providing you with is there for a reason. And don't look at it in any other way. If you start doing the other stuff, it just makes it harder rather than easier. And our next little slide, we'll actually talk about the anatomy of particular board style questions. So the anatomy itself consists of basically what's called a stem, and the stem is basically the body or the main section of each question. Then you have the lead-in, which is the question itself, and is the one that usually ends in the question mark. Then you have the key, which is going to be your correct answer, and then you also have the distractors, which the distractors in this case are not, something distracting within the stem. The distractors are just the incorrect answers. If you look at the next slide, we can actually see it's all kind of color coded for. So here is our stem once again in green. Our lead-in is in pink. Our key is in yellow, and our distractors are in blue here. So once again, the stem is the body or the paragraph of the question. It usually starts with a patient of some age presenting to some location, followed by some complaint. And this is the most important portion of the question, or of the stem. If there's one thing to take away, it is definitely that initial phrase, and usually it's the first sentence. And here we can see that we have a 38-year-old female presenting to the emergency department with chest pain and shortness of breath. So after this point, they're going to provide you with additional information. Some of that additional information might be, history of present illness or past medical history or past surgical history or some social history. It might give you a medication list. Usually they toss in some vital signs and some physical exam findings. And usually they wrap it up with some lab findings or diagnostic tests, like a chest x-ray, an echo, a CT scan. And it's usually pretty much in that order. So you can expect the first sentence to usually pretty much read, a patient of an age presenting to a location with some specific complaints, followed by, the HPI, the past medical history, surgical history, social history, wrapping that up with vital signs and a physical exam, and then plus or minus labs and diagnostic stuff. So if you're going through your question and you realize, I really would have expected them to have included this lab finding, and I'm not seeing it in, the kind of the section that they're covering labs. They didn't hide that in the first part of the STEM there. So don't go look for it in other places. That will actually just slow you down. So after we get through the STEM, we're going to look at the lead-in. Now the lead-in is, again, it's the question itself, and depending on what they're actually wanting to ask you, this can be lots of different things based off the STEM that's provided. They can ask, what's the most likely diagnostic test? What's the mechanism of action of some drug, or what's the mechanism of some disease state? They can ask you about physical exam findings, or initial treatments. They can ask you about lab findings that you might see. Once again, this can change drastically from each question. After that, you have again your answer choices. Once again, the key is the correct answer, which again here is platelet count, and our distractors are our wrong answers. So just to kind of walk through this question one more time, we'll just kind of go from the top. So here we can see in our STEM that we have a patient that's presenting with signs and symptoms of a pulmonary embolism. She's presenting after a long plane flight with chest pain and shortness of breath. So that should kind of key us in on pulmonary embolism. So, and if we look down in there at the lead-in, they're wanting to know a laboratory test that's used to monitor the patient for complications. So we already know that we're going to have started them on a treatment. So based off of the lead-in, we know that they have been started on a treatment, and we know that the treatment here is for a pulmonary embolism. So this is definitely a multi-step reasoning question. So first we had to come up with, they have a pulmonary embolism. Second, we have to come up with, they've been started on treatment, and we have to decide what treatment that is and its appropriateness. And then from there, decide what is the complication of that treatment. So you have to get the treatment right to get the correct complication to the treatment. So how do we treat PEs? Well, these are usually treated with either anticoagulation or some form of thrombolytic. And how do you decide if they're going to get a thrombolytic or not? And usually that's decided if they're stable or unstable. And usually unstable here is defined as like shock. So is our patient here in shock? Well, no, she's not. Our blood pressure is pretty good, 117/82. Heart rate is a little high, it's 106. And respiratory rate's a little up at 23, but these are not, just catastrophically terrible vital signs. So she is not in shock. So we would treat this patient with anticoagulants or anticoagulation. So there's a few anticoagulants or anticoagulation that we can use. Heparin is one, warfarin is one, apixaban, dabigatran, rivaroxaban. Those are also others. So which one of those can lead to a fatal immune-mediated complication? And that is the key there, immune-mediated complication. Well, the one that can do that is heparin. And it does that through causing heparin-induced thrombocytopenia, or HIT, which can be fatal, and it does cause clotting. Clotting is the key finding there with heparin-induced thrombocytopenia. It's not bleeding, you get clotting. And the way we monitor for this complication is by the platelet count. And for those of you that are kind of interested in scoring systems, there's called the 4T score. You can look that up, and it'll tell you if your thrombocytopenia is actually due to HIT or is it due to some other cause. Kind of a pro tip here, just to toss out, if you ever get a question on a pulmonary embolism, I've never seen, and I've worked, I think I counted one day, over 40,000 questions. I've never seen the pulse be under 100 and the question be talking about a pulmonary embolism. So if you get pulmonary embolism as what you think is the correct answer, make sure that your pulse coincides with that being the what you think is correct. But once again, so if you have a PE, look for a heart rate over 100. All right, and that will kind of wrap up that. So once again, this is just kind of how I approach board style questions. And the thing that I want to point out here is it's not so much that you do it the way I do it, but it's just that you have a process or a way that you work through questions. And the reason you want to do this is just so you can avoid kind of careless mistakes. Just like how you learn how to read EKGs or ECGs, chest x-rays, or even acid-based problems. You just want to have a way that you walk through the question from top to bottom. And once again, it just helps you avoid kind of making, for lack of a better word, a dumb mistake. So the first thing I do is I look at the lead-in or the questionnaire itself. And I do this so that it will give me a sense of kind of what they're asking me and help me frame my thought process. Because once again, this is a thinking exam. This is not a rote memorization exam. If you just base it, your ability to answer questions off of memory, i.e. you have seen them before, only about 30 to 40% of the exam is what we kind of call memory. 60 to 70% of the exam is based off your ability to think. So if you can't think, then you don't do well on these exams. So we want to be thinking. So when I looked at the lead-in first, it kind of helped me frame my thought process, which help me think better. That's kind of the reason I approach the lead-in first. After that, we want to look at, or at least I look at the answers. So once again, I'm just going to look through each answer and kind of see what they're talking about and see where I need to focus when I actually read the stem. Then I'm going to read the stem. So, I've looked at the lead-in, I've looked at the answers. Now I'm reading the stem or the body of the question itself. After I've done this, I go down and evaluate each answer and give my reasoning as to why I think, answer A is correct or incorrect, answer B is correct or incorrect. And I do this for each answer. And it's very brief. It's me describing the process is kind of long and drawn out, but this is a very quick move. Then I will actually pick an answer, pick the best answer based off the information that I have from here. And then the last little bullet point I have here is move on. And the reason I put this here is usually after you've applied a thought process or a way or an approach to questions, staring at the question for an extra minute or two is not going to actually help you get the question any more correct. It's just going to waste your time. And wasting your time is very important in these tests. The rate of turnover for each question, you need to be moving. You don't want to spend more time than you need to, because it will cost you kind of down the line. And we'll make sure you get to every question, because again, you're trying to get as many questions right as you can. That's how we get our best scores. So, all right, now we will take a look at a question. All right, so we're just again going to work this one just how I kind of go through questions. So the first thing we're going to look at is the lead-in, and the lead-in here states, which of the following laboratory findings would you expect to find in this patient? So once again, we're looking at a laboratory finding. That's what they're wanting us to know about. Again, next I'll look at the answers. So we have our answers here. We have decreased ceruloplasm. Sorry about that if I butchered that word. That's answer choice A. And then B, we have elevated alk phos. We have C, elevated carbohydrate antigen 19-9. We have D, positive antimitochondrial antibody. And we have E, positive cytoplasmic anti-neutrophilic cytoplasmic antibody. So just to kind of talk through each one of these answer choices. First up for our ceruloplasm level. Now, what is this usually discussed in? Like in terms of this laboratory finding, what is it usually talked about? Or what disease is usually talked about? Well, that's going to be Wilson's disease or hepatolenticular degeneration. That's the fancy name for it. They're trying to get rid of eponyms, so just another kind of tip here. I would expect hepatolenticular degeneration to show up on your exam, not Wilson's disease, even though I might kind of refer to this as Wilson's disease. So if we expected A to be the correct answer, then we'd expect the question or the stem itself to talk about Wilson's disease. So that's kind of what we would want those two to match up. So if our question is going to talk about Wilson's disease, what would we expect the stem to tell us? Well, we would expect them to kind of say stuff that's similar to Wilson's disease, which is usually due to copper accumulation within organs, and it presents in someone less than 40 years old. So in that opening sentence, we expect to see someone less than 40. We'd expect them to have signs and symptoms of liver dysfunction, like cirrhosis or liver damage. And then we'd also expect to see some neurologic or psychiatric findings. They might even give us an image, and that image would be of the, maybe the Kaiser Flasher rings, which can be seen around the eyes. And you can see an example of that image here. I think there's a picture. Well, there should be a picture that pops up. Yeah, there we go. Okay, and you can see an example of that picture here. And our lab work, if we were to get lab work for Wilson's disease, we would see low ceruloplasm levels and elevated urinary copper. So that would kind of be what they would talk about if we expected to pick A as our right answer. So next we have elevated alk phos. So, kind of what can we know about elevated alk phos? Well, a lot of things cause an elevated alk phos. From infections to pregnancy to anything that causes increased osteoblastic activity. This could be like Paget's disease, or even just a healing bone fracture. You break your leg, you're going to have elevated alk phos levels. Other things that can cause it are liver disease. And this can be anything from liver damage secondary to just like alcohol, or liver damage secondary to obstruction, which could be like a stone or a stricture or even a mass. So lots of stuff to think about when we think about elevated alk phos. Next we have is elevated carbohydrate antigen 19-9 or CA19-9. Once again, this is another thing that can cause lots of things can cause elevation in this number. And just once again, another kind of pro tip, CA19-9 is rarely ever going to be the correct answer if you're picking answers. So if you get down to the last question of the test with 2 seconds left and CA19-9 is an answer choice, just don't pick that one. Pick one of the other ones. It's rarely ever the correct answer, and it's because lots of things cause elevated CA19-9 levels. That's one reason. The other reason is it's only the correct answer usually when monitoring for treatment of pancreatic cancer. So if you had to remember one thing about it, it would be remember pancreatic cancer. But once again, lots of stuff can cause elevated CA19-9 levels. Any form of basically disease of the pancreas or hepatobiliary system can cause elevated CA19-9 levels. And even some weird things like CHF and Hashimoto's thyroiditis and bronchitis can all cause elevated CA19-9 levels. So if this question was talking about if they had framed it where CA19-9 was the correct answer, once again we'd be expecting them to talk about pancreatic cancer. And how would pancreatic cancer present? Usually it's an elderly male with painless jaundice and weight loss. So that's kind of the things we'd be expecting to see in the question. Our next answer here is we have our positive antimitochondrial antibody. So what disease is this typically seen in? Great. That's going to be primary biliary cholangitis. Used to be referred to as primary biliary cirrhosis, but they changed it to primary biliary cholangitis. So still the same acronym, PBC, but just the last name's changed. So what do we typically see here? Well, once again, we'd see usually it's a female that's 40 to 50 years old, and they're going to present with fatigue, pruritus, and xanthelasma, or cholesterol deposits under the skin. So once again, that opening line would be a female of that stated age presenting due to maybe pruritus or fatigue or just not feeling very well. And then she would present to your office. That'd be a classic presentation for this. She would atypically come to the ER. So you wouldn't expect to see her in the emergency department. Here you can also see elevated ALK phos levels in primary biliary cholangitis, and you can also see osteoporosis. Now, the bilirubin for primary biliary cholangitis will classically be normal, and that's one way to tell primary biliary cholangitis apart from primary sclerosing cholangitis. Once again, primary biliary cholangitis, or PBC, will have an elevated ALK phos with a normal bilirubin, while primary sclerosing cholangitis, or PSC, will have an elevated ALK phos and an elevated bilirubin. But just to give you full disclosure on kind of the content there, primary biliary cholangitis can have an elevated bilirubin, but is usually way later in the disease course. So it's kind of as the disease starts to kind of burn out as you're approaching that liver transplant. So for board exams or for board questions, it's easy way to differentiate those two is primary biliary cholangitis, think elevated ALK phos, normal bilirubin. Primary sclerosing cholangitis, think elevated ALK phos, elevated bilirubin. And now our last little option here is answer choice E, which is a positive cytoplasmic neutrophilic, anti-neutrophilic cytoplasmic antibody, or c-ANCA. That's the other name for this, is c-ANCA. So what's c-ANCA associated with? There you go. It's going to be granulomatosis with polyangiitis, or Wegener's or Wegener's, depending on how you want to pronounce it. Now, a positive c-ANCA is also associated with a positive anti-PR3 antibody. And what I will also tell you is that tests are slowly moving away from positive CMP ANCA to positive anti-PR3 and positive MPO. The reason they're doing that is just the way the tests are run. The C-ANCA and P-ANCA are a little more reader dependent, meaning that the pathologist or the laboratory person that's reading it can just make a mistake. While the positive anti-PR3 and the positive MPO, basically the test itself just kind of reads as being positive or negative. There's no interpretation bias that can go on there. So some of the classic symptoms for Wegener's or Wegener's are what we kind of remember with the mnemonic ELKS, ELKS, where E will stand for the ENT findings, the L will stand for lung findings, the K will stand for kidney findings, and the S stands for skin findings. So in the ENT area, what would we kind of expect to see? Maybe recurrent sinusitis or malformations of the nasal septum leading to perforated nasal septum or saddle nose deformity. For the lungs, we can see hemoptysis or cavitary lesions. For the kidneys, we see glomerulonephritis, which classically presents with bloody urine with dysmorphic red blood cells and red blood cell cast. And for skin, we see a vasculitis, which can present with petechia and purpura. And you can see an example of that image here. I think there's an image of petechia and purpura as well. All right, so great. So once again, if we expect E to be the correct answer, we'd expect a presentation pretty consistent with a Wegener's or granulomatosis with polyangiitis, which would have those findings that we just discussed. All right, so now let's look at our skin. Good, there we go. So here we have a 43-year-old man that's of Eastern European descent who comes to the physician due to worsening bloody diarrhea, cramping, progressive fatigue, and intractable pruritus. So once again, we have that classic setup. We have a person of stated age presenting to a location, which is just in this case a physician. So I would expect it to probably be like an office-based thing. And then due to complaints, and his complaints are bloody diarrhea, cramping, progressive fatigue, and intractable pruritus. He has a medical history of ulcerative colitis. His vital signs show a temperature of 98.8 degrees Fahrenheit, blood pressure 105/80, heart rate 103, respiratory rate 20, oxygen saturation 98% on room air. Physical exam reveals that he looks tired and he has some scleral icterus. In addition to a total proctocolectomy to alleviate his GI distress, the physician orders endoscopic retrograde cholangiopancreatography, or ERCP, which reveals alternating strictures and dilations of the bile ducts. So, and then now we get into once again the lead-in. Which of the following additional laboratory findings would we expect in this patient? And we have our answers: A, ceruloplasmin, decreased ceruloplasmin; B, elevated alk phos; C, elevated carbohydrate antigen 19-9; D, positive antimitochondrial antibody; and E, positive cytoplasmic neutrophilic cytoplasmic antibodies, or CANCA. All right, so now we'll give you a little bit of time to kind of think through that after kind of all that other stuff we discussed, and see if you can come up with the correct answer.
All right, so if you guys have figured out a correct answer, I'm going to go ahead and open up a poll, and we're going to let you answer the question. So here we go. All right, you should be getting the poll on your device or your laptop or your PC. So go ahead and pick an answer. And again, we will leave this open for a good 30-40 seconds because it's going to take a little time to tabulate. And if you don't know, just don't be shy. Go ahead and select what you think is the best answer. As you recall in the USMLE Step 1, there is no penalty for guessing, so they're not going to subtract anything, for guessing. So under no circumstances should you ever leave your exam or an item blank. At the end of the day, you got to pick something, commit to it. All right, looks like half the folks have answered. I'm going to leave it for a couple more seconds and wait till at least till we get 2/3 of the folks answering. I think we're almost there. Okay, it looks like 2/3 have answered. Let me go ahead and close the poll and share the answer, the spread, and okay, let's see, you should be able to see it. So looks like the two most popular answers is D, antimitochondrial antibodies, and B, elevated alk phos, and then there's a scattering among the rest. All right, and so let me go ahead and hide that, and then we'll move on to the next slide. And the answer is B, elevated alk phos.
All right, so the answer here, like I said, states is elevated alk phos. And once again, we had to decide if we thought this was basically primary sclerosing cholangitis or primary biliary cirrhosis, or cholangitis. And this is an example of primary sclerosing cholangitis. And if you can advance to the next slide, we'll take a look at just the question itself. So once again, they're going to give us the page of a stated age due to, once again, the complaints. And then they're going to kind of fill us in with, some other vital signs, the physical exam, those type things, which they've kind of all done that there. So once again, this is definitely a two-step question. They're asking us, we have to make the diagnosis in our head. And then once we made the diagnosis, we have to associate the laboratory finding with that diagnosis. So as we kind of stated about earlier, the reason D is not the correct answer is D is discussing primary biliary cholangitis. And remember, that's classically seen in a female 40 to 50. I know this is a male, so that's one reason that's a little off. And they didn't give us lab findings about the alk phos or the bilirubin, so we couldn't use that to answer our question. But they did give us ERCP findings, which reveal the alternating strictures and dilations. And that is very classic for primary sclerosing cholangitis and something that you will not see in primary biliary cirrhosis. So other kind of classic findings that you see in primary sclerosing cholangitis are going to be the, you can get pruritus as well. You can see jaundice. Once again, it causes that elevated alk phos as well as elevated bilirubin. And then, a few other things that you can notice about the disease is typically it's seen in males. That's just kind of the classic presentation is usually a male. And usually it's a male, kind of in that same age range is the primary biliary cholangitis, 40 to 50 age range. And that they usually have a past medical history of ulcerative colitis, which they gave us here. So if you're reading a question or working questions and you're wondering if it's between primary sclerosing cholangitis or primary biliary cholangitis, look for that inflammatory bowel disease history, which can be Crohn's, but classically it's ulcerative colitis. And look for the ERCP findings or MRCP findings of the strictures and dilations. If you see that, then it's primary sclerosing cholangitis as opposed to primary biliary cirrhosis. So what does this image actually look like of this ERCP, with this alternating strictures and dilations? And we've got an example of it here. And this is kind of what you see. So in this case, they've taken a catheter and they've placed it into the biliary ducts of the liver. And you can see just the areas of dilation followed by the strictures kind of all throughout the biliary system there. So once again, that's kind of what leads to this being the correct answer. And you can remove the image now. So to kind of talk about the other options, we have the ceruloplasmin level, that would be Wilson's disease. And once again, this is definitely not Wilson's disease. Nothing to kind of make us think Wilson's disease, youngish person. They are a little youngish, but they're not having any neuropsychiatric problems. Again, the CA19-9 level, they're not talking about pancreatic cancer here. I would tend to argue that the CA19-9 level is probably elevated in primary sclerosing cholangitis, but that's still not the best answer. The best answer here is going to be the ALK phos level. The antimitochondrial antibody, like we stated earlier, primary biliary cholangitis is usually female, no history of inflammatory bowel disease, as well as no ERCP findings of strictures and dilations, kind of as we saw there. And then the positive C-ANCA, once again, that's seen in granulomatosis with polyangiitis, and they didn't give us any of those findings, remember, from the Elks mnemonic that we talked about earlier. All right, well, great. That will wrap up that question. And now we'll take a look at the next question. All right, so here you can see that the stem itself is very similar. The lead-in has changed as well as the answers have changed. And this is kind of how we're going to do this review, where basically we walk through how one stem could be approached for many different lead-ins and many different answer options. So this one might be kind of easy because we've already discussed a lot of this, but this is just to kind of give you an example. So once again, we have this question, which is we have a 43-year-old man of Eastern European descent who's coming to the physician due to worsening bloody diarrhea, cramping, progressive fatigue, and intractable pruritus. He has a medical history significant for ulcerative colitis. His temperature is 98.8, blood pressure is 105/80, heart rate 103, respiratory rate 20, oxygen saturation 98% of room air. Physical exam, he looks tired. He's got some scleral icterus. In addition to a total proctocolectomy to alleviate his GI distress, the physician orders ERCP, which shows the alternating strictures and dilations of the bile ducts. And then it's asking, which of the following is the most likely diagnosis? So for this one, they want to know the diagnosis. Last question, they want to know the lab findings. And here we have Wilson's disease, autoimmune hepatitis, primary biliary cholangitis, primary sclerosing cholangitis, and then fibromuscular dysplasia. So we'll give you a chance to think about that and then pick an answer.
All right, so you guys probably don't have to think too much since we kind of spent some time. So let me go ahead and open up the poll. Hopefully you guys lock onto your answer and expect a much bigger improvement this time. So let me launch that and have at it. So please pick an answer. And we will we'll wait till about maybe we get half the response because I know we got a couple more questions. So I'll just kind of interject that one of the things that you can do when you're doing Qbank questions like USMLE-Rx is just do exactly what Dan did here, which is quiz yourself on how else they could use this question, this stem or this case to ask a question. Could it be about the diagnosis? Could it be about the treatment? Could it be about the mechanism of disease? Or could it be about the most likely side effect of the most likely treatment for the most likely diagnosis? So you can kind of create your own multi-step questions to really stretch yourself. So in a way, you're kind of seeing a little bit this with the case variation here. So let me go ahead and close it and share the response. And as you can see, most people have gone to primary sclerosing cholangitis, PSC, which is what, let me go ahead and hide the poll, sorry, which is what Dan was talking about. Let me hide that and then move on to the answer, which is again PSC. Back to you, Dan.
Great. So, PSC is the correct answer, D. And you can just advance the slide to the next. It's going to be the same question. Just to talk through it real quick. All right. So for this question again, once again, the STEM is the same, but the lead-in has changed. And again, they're asking for the diagnosis. This is a single-step reasoning question. They just want to know the diagnosis, and they've given you the STEM. Yes, it's fair game for your exam, but this would be kind of a little bit more simplistic. As we kind of already discussed, we have someone with ulcerative colitis presenting with the ERCP findings, and you can see the image again. I tossed it in there, I do believe, as well as some pruritus and scleral icterus. So once again, this is all very classic for primary sclerosing cholangitis, and they just wanted us to know the answer. Just to kind of review the other answers, again, Wilson's disease we've already discussed, the copper buildup leading to the neuropsychiatric stuff, and you have the Kaiser Flasher rings. Which once again. Here's I think I put in the picture of the eye again as well, which you can see. Then we have autoimmune hepatitis. This is classically seen in an adult female, and the most striking abnormality that they would usually talk about is elevated LFTs with where the AST and the ALT can reach into the thousands. And not a lot of things can do that. So, remember the short list of things that can kind of elevate your AST and ALT into the thousands. It's like shock liver, viral hepatitis, Budd-Chiari, not Budd-Chiari. What you got? The clot within the billy. What you got? The somebody help me. What's it called? We get a clot within the hepatic vein. It's not Budd-Chiari malformation. That's the brain thing.
Sorry,
oh well. Anyway, we'll move on. But the short list of things that can cause elevated AST and ALT into the thousands. Your acetaminophen overdose, shock liver, the autoimmune hepatitis, and then the clot within the hepatic vein, which has its own name. And you can apparently just go look it up because I've forgotten the name. I'd be able to recognize it. And this is going to be associated with positive anti-smooth muscle antibodies or anti-liver kidney microsomal antibodies. If they gave you, they wouldn't give you ERCP findings for autoimmune hepatitis. So if you have those, we know we're talking about primary sclerosing cholangitis. Then for primary biliary cholangitis, once again, we already talked about it. It's usually in the females. You get similar symptoms, but they don't have elevated bilirubins, and once again, no ERCP findings there. And then for fibromuscular dysplasia, this is usually seen in middle-aged women, and they get abnormal growth of the walls of their arteries, and you get focal narrowing followed by small aneurysms. Classically, it's seen in the renal blood vessels, but it can present with within any blood vessel system, and usually presents with hypertension. So if you get a young female presenting with hypertension, that's kind of the thing that you're looking for there. And this would be the image of what you call it, the fibromuscular dysplasia. There you go. So, and this is of an arteriogram or angiogram of the renal arteries. We classically see the beads on a string, which is kind of a stricture and dilation appearance, and it just basically causes focal narrowing with aneurysms and dilation. So just if we advance the slide one more time, we're going to get basically two similar images. So here's the two similar images of primary sclerosing cholangitis and fibromuscular dysplasia. And what I just wanted to point out here is if you just remember beads on a string or alternating strictures and dilations, like as they describe it in words, you can miss this question. It would be kind of hard. One's kind of GI related, one's like young female with high blood pressure. But every once in a while, we'll, talking to students, they get fibromuscular dysplasia and PSC confused. Just because they read in the STEM, they see alternating strictures and dilations, and they go down there and pick an answer. And what I'm just trying to point out is that one of these is done by, it's a GI doctor that's going to do an ERCP, which is a scope that goes through the esophagus, into the stomach, then into the small bowel, and they pass a catheter through the pancreatic duct, and they evaluate the biliary system, and that's what primary sclerosing cholangitis is. The other one is a cardiologist or an interventional radiologist that basically gains access to the femoral artery, drives a catheter out to the renal arteries, and uses dye to look at the renal arteries. So completely different organ systems, even though they might have similar appearances, which is kind of that beads on a string or alternating strictures and dilations. So now on to our next question. All right, so for this question, once again, we have the same stem. We've omitted a sentence, and then the question that they're asking is, which of the following disease states is most associated with this condition? So we have an associated disease. This would be a two-step question. I'll just read it real quick, and then we can basically pick an answer. So 43-year-old man, Eastern European descent, comes to the physician with worsening blood diarrhea, cramping, progressive fatigue, and intractable pruritus. Vital signs, temperature 98.8 degrees Fahrenheit, blood pressure 105/80, heart rate 103, respiratory rate 20, oxygen saturation 98% or more. Physical exam, looks tired, some scleral icterus. In addition to a total proctocolectomy to alleviate his GI distress, we get an ERCP, which shows the alternating strictures and dilations within the bile ducts. Which of the following disease states is most associated with this condition? So it's a two-step question. We have to once again come up with our diagnosis and then think of the associated disease. And our options are A, celiac disease, B, primary sclerosing cholangitis, C, primary biliary cholangitis, D, microscopic colitis, and E, ulcerative colitis. So once again, looking for the associated disease, and which one do y'all think is correct?
All right, give you guys a moment, and then I'll go ahead and open up the poll. All right, go ahead and pick an answer. All right, looks like about half you folks have answered. I'll wait a couple more seconds. All right, I'll go ahead and close the poll and share the answer. And not surprisingly, the majority of folks picked ulcerative colitis, but some of you guys went back to PBC PSC. So I think Dan will walk you through the lead in, and in fact, what is this question trying to get at? So let me go ahead and hide the poll, and then we're going to move to the answer, which is ulcerative colitis. Back to you, Dan.
Yeah, great. So we have ulcerative colitis here, and if we want to just advance the slide looking at our question itself. So here's our question. The key here, or when it's presented in kind of tandem with our other questions, this question could be actually a little easier just because we've kind of been preloaded with the other stuff. But this question could be potentially difficult if you didn't quite understand what the lead-in or the question was actually asking. Once again, it's looking for which of the following disease states is most associated with this condition. That is not asking for a diagnosis. Once again, remember, just because you want it to ask for the diagnosis doesn't mean that it actually asks for the diagnosis. So answer the question that's in front of you, and that's sometimes hard. I remember being at a point in time in my life that I would always get thrown up on questions kind of similar to this, and the reason would be that I just didn't answer the question that they asked me. I wanted to answer some other question. So this would be a two-step question again. They give you a presentation. We have to come up with the disease, and then from that disease, think about the associated condition, which again in this case is ulcerative colitis. Remember, your inflammatory bowel diseases are very commonly associated with primary sclerosing cholangitis. Primary sclerosing cholangitis is not the correct answer because that would be the diagnosis, and they didn't ask us for the diagnosis. And in our text box, once again, it's just showing how the stem itself could be used again, just covering up the fact that he has a past medical history of ulcerative colitis. And that's what we covered up there. And if you advance the slide or just hit next. There you go. So the past medical history is significant for ulcerative colitis. So they just took out that single sentence that could ask you this question, which is asking about an associated disease state. So, and that's really all I wanted to point out there. So on to our next question. So here we go. This is once again the same stem. I'm not going to read it this time. I think I've read it enough. But they are asking for which of the following is the next best step in management. So we have a management question. This will be, again, a two-step question. We have to come up with the correct diagnosis, which we've kind of done at this point. It's primary sclerosing cholangitis. And then they want us to know the management of primary sclerosing cholangitis. And our answer choices are A, urodesicolic acid, B, suppressive antibiotics, C, prednisone, D, IVIG, and then E, penicillamine. So just give you kind of a chance to think about it, and then we will answer it.
All right, let me go ahead and open up the poll and see what you guys think. Last question, so make it a good one. All right, looks like about 15% of you guys have answered. Keep it coming. Don't be shy. All right, so we got about 60%. I'll leave it up. Okay, let me go ahead and close the poll and share the answer. And it looks like the most popular answer is prednisone followed by ursyl deoxycholic acid. So let's see what the actual answer is. And it's A.
So this is ursyl deoxycholic acid. Once again, this is a harder question. It is a two-step question. You can go to the next slide just to kind of review the question. It is a two-step question. And the main thing I wanted to reiterate through this entire kind of webinar was just the fact that one single stem could have multiple lead-ins attached to it, and therefore, looking at multiple different questions. So we had a question on associated lab findings, we had a diagnosis question, we have the associated disease state question, and then we had the management question. The management question is classically a step 2 and even really more of a step 3 question. So that's why I don't really think this is going to show up on step 1, and probably why this question was a little harder for everybody. Urodeoxycholic acid is used for symptomatic primary sclerosing cholangitis. And how do we know they're symptomatic? It's actually because he has pruritus and scleral icterus. So that's how we know he's symptomatic. The other answer options actually don't serve any utility in treating this disease. They've tried them all in trials and stuff like that, and they're actually ineffective. After uroxycholic acid, you can also use cholestyramine. That's another potential answer treatment option. And then it's just liver transplant. So there's just not a lot of great treatments for primary sclerosing cholangitis, which is kind of sad. The stuff you need to know about uroxycholic acid is that it is it's a form of a bile acid. So in primary sclerosing cholangitis, we actually get buildup of bile, bilirubin, which once again it's a kind of a byproduct. Bilirubin gets broken down and put into bile. We get a buildup of bilirubin, so and then we're taking a bile acid, so it's kind of counterintuitive if you think about it. So why would you want to take something that your body's trying to get rid of? And the reason you do it is it actually binds the cholesterol in your diet. So it's going to bind up all the cholesterol, and then the cholesterol is not going to be reabsorbed, and it's going to be excreted through your feces. And remember, cholesterol is used to make bilirubin. So and that's how it does it. So it decreases overall bilirubin production by increasing cholesterol excretion. So that's kind of how the mechanism of action of that drug there. So once again, uroxycholic acid, that's going to be your correct answer. The other ones, don't serve any role for this disease. Once again, harder question just because it was asking management, and most of the time we're talking about step 1. So for our last slide, just to kind of for your information, talking about the differences between primary sclerosing cholangitis and primary biliary cirrhosis. If you want to screenshot it or something like that, feel free. But this is just kind of the common associated findings and stuff you need to know about each of those diseases. But we won't go any further into that. And I think that wraps me up.
All right. No, we got the dissection tips. You want to go through this one?
Yeah, just real quick. So once again, the main thing I want to point out kind of just as from the talk is once again, have an approach. Once again, it doesn't matter how you have an approach. It doesn't matter what your approach is, but just have a way that you go about it. Like reading a chest x-ray or reading an ECG, just so that you can hopefully not make careless mistakes. The other thing is just to know the format. So know that there's a stem, there's a lead-in, there's keys, and there's distractors. Once again, the stem can stay the same, but the lead-ins can change. And an easy way to kind of test yourself is, once again, just gonna give yourself different lead-ins for different stems. Want to use all the information they're providing you when selecting your answer. That's basically kind of going back to that thing I stated at the beginning. Don't assume that they're trying to trick you or eliminate or eliminate sentences within the stem just because you don't think that's associated with what they're talking about. And then once again, every question is created to test a specific topic or content area. And if you can ask yourself, what are they likely trying to test me on here? Sometimes that can help you get to the correct answer.
All right. Okay, so Dan, thanks for that phenomenal master dissection and really showing everyone how a single stem can be used in so many different ways to ask so many related questions that can still be very challenging. So just to wrap it up with a couple other thoughts, some advice here. One is when you prepare for the step one, you do want to plan ahead. You should try to establish a study schedule, and once you do it, you should be able to stick with it if you follow a couple of simple rules. One is you don't want to over schedule, so you schedule in breaks for exercise and just to be a human being, right? And so even if you're in dedicated time, even if you're in IMG, even you have multiple months, just to be able to concentrate on this, take at least a day off a week, slow down the studying and space things out. I also, as a corollary, would suggest that you want to try to at least get through all the primary studying 1 to 2 weeks prior to the exam, because inevitably things will run late. You're going to have to maybe revise a couple areas, maybe do some additional tests to kind of troubleshoot where your challenges are, and so you'll need some of that time. The other thing that you might want to do is you might want to order the crammable subjects towards the end, and from a discipline standpoint, the ones that tend to be a little bit more crammable are things like microbiology, so the drug and pharmacology, so bugs and drugs tend to be a little bit more crammable because the structure and the relationship between the concepts tend to be fairly well baked, and it's less so with pathophysiology. The other area that tends to be also a little more crammable are metabolic pathways, again, because it's talking, conceptually it's really the same thing: pathways, substrates, enzymes that can inhibit or elevate a pathway. So those tend again to be crammable. A couple of things to keep in mind is that while that you have a tendency to cram, you want to really avoid it if at all possible. And so that means thinking about other other study techniques that are really evidence-based, and the big one actually is self-testing. So that in fact that's actually doing questions exactly what we do, and the data that we show is that the more questions you do, the better. And for those who are doing USMLE-Rx, if you are using USMLE-Rx, if you do the entire question bank, it should give you close to 10 additional points on the boards, controlling for undergraduate GPA and MCAT. So it helps all folks, wherever your starting point is. And then the other thing to consider is, if you had a reasonable medical school experience, a lot of the material should have been covered, and so you're going to spend a lot of time focusing on what you previously learned. And then in the front of the book, we do have a checklist that will kind of help you stay relaxed and grounded in terms of planning in the weeks to months ahead for the USMLE Step 1. And that's pretty much the primary discussion here. We appreciate the chance to talk to you guys. You can also reach out to us through social media, Facebook, Twitter, and Instagram. Our blog at firstaidteam.com, where there's a copy of this, a recent copy of this talk. You can download the PDF, under free talks, in the menu bar.